I started here with 12 surgical interns, and at that time we had a very steep pyramid. Only one would be a general surgical chief resident, maybe two. The program then accepted only one of my group, and they selected somebody else who unquestionably was a better candidate. He turned it down, and that's how I got the second year here. I did a little research on my own. There was no formal research program. And I stayed on, and Dr. Merle Scott was the chairman when I finished. And he asked if I would stay on the faculty as a junior instructor. In the interim, I had done a book on surgical diseases of the liver, because that book was the first English book, comprehensive book on surgery of the liver, published by McGraw-Hill. And they were generous with allowing me to do illustrations, and I had Tom Starzl do the chapter on transplantation, which actually was done before he had a successful liver transplant. That field should be credited to him, obviously. The book did well, and John brought together people who had worked with McGraw-Hill. Dr. Shires had done a book on electrolytes and shock with him. They had had an experience with Richard Lillehei from Minnesota, and I don't recall what that was on. Frank Spencer had done chest surgery with them, and he was a notable cardiac surgeon at NYU. And Ed Storer had done a book on the stomach, I thought. So they brought us together in New York. John arranged for us to have meet each other mainly at Mr. McGraw's box at the Yankee Stadium. So Frank Spencer, I recall, said, if Sy'll take the lead, fine. And I did, and I didn't realize it was an onerous position. But we decided to do a different type of book, emphasizing anatomy and physiology and going from there. Plus, as was noted in the first edition, we had 52 chapters, one for each week, so the residents could, or people could say, I'll do a chapter a week, and incorporated all of the fields of surgery. And that's the way it came about. I think it was about, in toto, about 2 to 3 years in preparation. And there were so many, as you know, we did this redux in which the Department of Surgery at the University of Rochester reviewed every chapter or every segment, including the specialties. The other major changes, I think, was this minimally invasive surgery came about, and that was related to biomedical engineering, not to surgery. Information became more available, and because we had more available, we had the greater availability to get rapid knowledge, we developed better data. The major operations that we invested money in illustrations in the first edition, the two main ones that consumed 11 and 12 pages apiece, were portal systemic shunts for bleeding varices. And at this institution, we haven't done one in the last 2 decades. So that operation is gone. The other thing is, radical mastectomy. I don't believe we've had a radical mastectomy done here for 2 decades, too. Plus, We didn't have interventional radiology. We didn't have MRI. We didn't have CT scan then. We didn't have endovascular surgery. Almost most peripheral vascular surgery is done endovascularly. We didn't have appreciation of how to grade tumors, the TNM grading of tumors. That didn't evolve until after the first edition. We didn't have some postoperative diseases and infections. There was no MRSA. There was no C. difficile. So for every advantage that we achieved with antibiotics, there was an occasional new thing that cropped that we had to learn to address. As I have pointed out to our residents, the one operation that most of the residents of my time, perhaps general surgical procedure, performed the most of was subtotal gastrectomy or vagotomy for peptic ulcer disease. In 6 months in the municipal hospital of Strong, I think I did something like 30. That operation is essentially not done now. I think immunotherapy, which probably Dr. Steven Rosenberg and his group at the National Cancer Institute, and I think gene-directed therapy, it's the second one, and transplantation has been an enormous explosion, and of course, minimally invasive and robotic surgery. As I had the wonderful opportunity of watching one of our transplant surgeons doing a kidney transplant robotically, and it was unbelievable. It was spectacular, really. The role of the teacher is to impart a passion to learn more, and that's a hard thing to do, really, because I think the field will change again. Yeah, I think for me it was a wonderful career, and I confess, I said, every day I've come to work, I've enjoyed it, really. And I guess there's more burnout now. I hadn't heard of burnout before. Many of the faculty are stopping their work at age 60. I advise people not to retire or find something else to do in the field of surgery or something related to surgery, period, or medicine. I think now patients are surviving where they didn't. I would think they'd look to exciting times. What is new is, I think it started when we were getting better data, and we were then we classified tumors, the TNM classification, and that continued. We had better diagnosis as to whether there was metastatic disease. We then, I think the first breakthrough was Bernie Fisher, the surgeon, and his brother, who showed that there was no advantage to doing a radical mastectomy. That was done by data. And once that came out, this led to evidence-based surgery. The evidence was doing a more radical procedure didn't achieve much. And the next thing was the use of adjuvant and neoadjuvant therapy. It didn't become a disease that only surgeons would address. That's number one. Number two, we were able to determine whether the tumors themselves could be modulated, or the defense to the tumor could be modulated by something like chemotherapy, hormonal therapy in the case of breast and ovarian tumors, or immunotherapy. And now it's a genetic approach. Does the genetic makeup of the tumor and the patient have a difference, period? And I guess that started with the BRCA genes with breast tumor too. And then you've had the issue of stem cell and doing away for hematologic disorders and replacing the stem cells of the patient. And that's become successful. So where there had been sort of a fatality in every case, or almost every case, now you can look for, and I do believe that things will improve. Lifelong learning is essential because the facts, in fact, change. They do. And you have, and I think the worst thing that somebody who is of an older generation to do is that things were so much better in our time. That's a cop-out, really. They weren't. They're better now. They're better for the patient, and it's important for the teacher to feel that it's better for him or her, too.